Hello and welcome to an interactive lecture on personal health management and family building with digital tools. I am Sarah Amaya, curriculum design strategist and webinar coordinator at ASRM. Our moderator for today's session is Dr. Wendy Vitek. Dr. Vitek is board certified in reproductive endocrinology and infertility and obesity medicine, and she's an associate professor at the University of Rochester Medical Center. As a CREST scholar, she developed a research interest in exercise and weight cycling in women attempting lifestyle change while undergoing fertility treatment. Before we begin, please note, this webinar was developed by the American Society for Reproductive Medicine as an educational resource and service to its members and other reproductive professionals. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. All attendees will be muted except the presenters. This is an interactive discussion, so please type a question in the question and answer window at any time. We will read as many selected questions as possible to the panelists. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. I will now turn the discussion over to Dr. Vitek.
Good evening. Thank you, Sarah, and to ASRM for hosting us. It's my pleasure to introduce a dear friend, Dr. Mahalingaiah, who's a reproductive endocrinologist at Mass General Hospital and also an assistant professor of environmental, reproductive, and women's health at the Harvard T.H. Chan School of Public Health. Her research focuses on the links between environmental and modifiable risk factors on human reproduction and gynecological diseases. She is the creator of the Ovulation and Menstrual Health Study and a principal investigator of the Apple Women's, and a lead investigator of the Apple Women's Health Study. Shruthi and I had the opportunity to study for our boards together more than 10 years ago. In the time that we started our training and our careers in reproductive medicine, many of our patients were tracking their menstrual cycles on paper. When you asked a patient, when's your next period, they would pull out a calendar, and how times have changed. I was sharing with her that I asked that common question in clinic, when do you think your next period will start? And a patient's like, let me ask my phone. And her husband laughed and said, when did you ever think you would hear that sentence uttered in your office? And I said, all day, every day. Our patients are spending a lot of time on their devices, and I'm really looking forward into learning more about this space with our expert today.
Thank you so much, Wendy. It's an honor and pleasure to be here today and share with the ASRM about this kind of emerging topic. And I just wanted to share on this initial slide that I have no financial conflicts of interest or disclosures in relation to conflicts of interest for this work. So this talk is going to be interactive, and Wendy and I will take you through some of these topics with questions. And this will cover a few aspects of how digital tools might be involved in different aspects of reproductive care, reproductive medicine, and prevention. So we'll talk a little bit about prevention and fertility care. What are the opportunities based on the demographics of our patient population? Talk a little bit about the impacts of obesity and reproductive health. What digital tools there are for health management. And then I'm going to share just a few points on a study that's just recently launched called the Apple Women's Health Study, and talk you through some of what we hope to work on in the context of this study. So with that, we'll think about prevention in fertility care. We're going to start with a question for the audience, and in a moment, a Zoom poll will pop up on your screen. The question here is, on average, How old are your patients that seek out fertility services? And there's 4 options. I know there might be a split between some age groups, but do your best to pick kind of the most common age category that comes to your clinical practice. I'll give you a moment. Different parts of the country or world might have different age distributions. And in a few seconds, once everyone has a chance to vote, we will see the results.
All right, so it looks like the poll responses show that most of our attendees are seeing patients in their late reproductive years. Age 35 to 40 was the most common answer, followed by 30 to 35, and then 25 to 30.
All right. The next icebreaker here is, on average, how many fertility-related appointments do you have with one patient before you initiate treatment? That could be 1 to 3, 3 to 5, 5 to 7, 8 or more, or not applicable, depending on how you engage with the fertility services. And different parts of the country and world may practice a little differently. So we wanted to get a sense of how often might you see a patient before they move on to treatment. We'll give everyone a moment before looking at the distribution.
Okay, so it looks like most are seeing the patient between 1 and 3 times. Some are seen more frequently, 3 to 5, but no one chose 5 to 7 or 8 plus. So you had mentioned, Shruthi, when we were talking before, that you've practiced in different settings, both a lower resource and a higher resource setting, and that you noticed differences in the number of visits you had or opportunities you had to counsel patients.
Yes, definitely, depending on the infrastructure and the type of practice. I think, at least personally, what I noted in certain areas, potentially in serving under-resourced populations with lower infrastructure, I was seeing my patients more often to relay intermediate results, a low TSH, an elevated prolactin, kind of relaying next steps, and kind of having a few more touch points before initiating a treatment plan. Sometimes the only option we had was really health optimization because the treatments themselves were out of reach financially or otherwise. So I think it's just something to keep in mind as we think about optimizing health during the fertility process. Here's one of our last questions for the icebreaker section. On average, what is the length of time between a patient's initial infertility consultation and treatment? And here could be 1.5 to 3 months, 3 to 6 months, 6 to 12 months, 12 or more months, or NA. And here, just getting a sense of how quickly does a patient get to move through, keeping in mind the different patient populations might have different time windows or resources to facilitate that speed of getting from initial visit to treatment. Give everyone a moment and take a look at those responses.
All right, so most respondents report 1.5 to 3 months, followed by 3 to 6 months. And again, that sort of tells us that we're seeing patients, we're seeing them fewer times, and we're pretty efficient at getting them into fertility care, but it does make us pause and wonder what costs, what corners are we cutting in order to provide that efficient service.
So taking a kind of overlapping look at age, reproductive age windows, and then when does weight gain occur, this kind of summarizes a lot of the concepts that we're conversing about today. So up at the top, we can see weight gain obviously progressively occurs through middle age. and leading to obesity. Weight gain is happening younger and younger. So people entering their reproductive years or menarchal years are actually coming in already overweight or obese. So that's something to also consider when thinking about this. And looking at, the overlap of peak fertility, fertility decline, and menopause, and when patients come in. So I kind of mapped out 34 to 35, but we can even move this green window over to kind of maybe 39 to 40. And that may accelerate kind of considerations here on health in relation to obesity and other health characteristics. Furthermore, if patients are coming in and their time to treatment is as short as 1.5 to 3 months, you can kind of get what I'm going for here. There's not a lot of time to pack in preventive counseling, health optimization in the initial infertility visit, especially if that visit might only that visit extend to maybe 1 or 2 visits, 1 or 3 visits, and occurs between a 1.5 to 3 month window. Of course, the treatment course may last from as little as 1 cycle to upwards of, 6 IUIs and 6 IVFs and more, with another consideration that most people are going to spend most of their time not in pre-treatment or treatment. So thinking about how can our tools extend impact for prevention, and timing of support seeking and lifestyle behaviors can be concurrent with or before coming in for that initial infertility visit. So a lot of times patients may have already done, and obviously it depends on the population, but a full quote unquote literature search where they go to Dr. Google, they start downloading their apps to understand what kind of fertility optimizing behaviors they can do. And the corollary of that, or the inverse, is that poor health behaviors may have been begun decades ago, and it's very hard to reverse these in a 1.5 month to treatment kind of window. So we all know the deleterious impact of substance use from tobacco and alcohol, with emerging literature on marijuana, which is now legalized in a variety of locations in the country. Poor nutrition, specifically high fat, high sugar diets, and other risks such as high BMI and lack of physical exercise. Health optimization is a challenge, as there are time constraints in fertility care. And as people are logging and tracking, and we're going to talk about that a little more, it's really challenging to undo some of their poor health behaviors, as well as non-science related learning that they've had on the internet. Wendy, I don't know if you've experienced this in your clinic, but I'd love to open that up here and pause for your thoughts.
Yeah, so there's a question in the chat, and I think this is probably a good time to just introduce that. Question about weight bias and health, and does BMI equal health? Thoughts on that? I can weigh in.
Yeah, I don't think BMI equals health. And we're going to get to that a little bit more when thinking about BMI thresholds and limitations in access to care. I think there's a lot of different factors that go into optimizing health, and BMI is only one of those. What are your thoughts?
This is really where the power of these digital tools could really bridge the gap, because we're using BMI in our clinics to maybe make assessments or false assumptions about someone's lifestyle or diet, exercise, past. And really, if we had more comprehensive data, we may be able to move away from BMI.
I agree. I also mentioned the other factors. There's a lot more to health optimization than only BMI. It's very hard to change BMI anyway in a short pre-treatment time window. I think you've led some of that work, and it's impossible to change age. So I think that we do have to think about what and how can we optimize health across the lifespan with digital tools. So BMI is one factor, but it's not the only factor. And we don't have a lot of time in our visits to undertake a full kind of reproductive counseling. So here, while across the lifespan counseling might help optimize health and reduce risk, I think one of the really important things is, where is this happening? Is it happening in the PCP office or other kind of locations? And I think what we're finding is that it's happening outside of the clinic altogether. And with more access to these tools, to my last point on this slide, I think younger and younger individuals are getting access to information around menstrual and reproductive health, not only around BMI, and there are two extremes. It's not just one extreme that's important. Both extremes, low and high, are very important to take into account. This part, though, does focus a little bit right now on obesity and reproductive health, specifically with the thought of what is healthy and what can we do to increase access to care. And so, Wendy, I'm going to turn it over to you here.
Yeah, just to get a sense of the practice pattern, is there a clinic IUI, intrauterine insemination BMI limit in your current practice? And we've listed the categories for BMI as 30 to 40 kilograms per meter squared, 40 to 45, 45 to 50, or no limit. Should have the results. Okay, most respondents say there is no limit for IUI based on a patient's BMI. Some do have a limit of 30 to 40. Some have 40 to 45. No one answered 45 to 50. And then as a follow-up question, we were wondering about how BMI is approached for patients undergoing IVF. Again, same categorization, 30 to 40, 40 to 45, 45 to 50, or no limit. So the first question was on IUI, the second question's on IVF.
Sorry.
No.
Yes. I think it's really important to think about these limits in terms of the distribution of BMI in the country and who can access care and the limitations of time we have, with a focus on safety. And we've heard a little bit about the practice guideline in a prior ASRM webinar, but just thinking about this with a preventive health lens, it's very challenging to intervene on this during a workup or treatment.
Yeah.
So sometimes one of the things that is discussed is, what are the risks of higher BMI, as opposed to how safe is the procedure in our clinical environment. And this audience knows what kind of some of the impacts are of obesity on fertility, pregnancy, and birth. But I think conversations around what is the safety within our clinics is another consideration as well. Specifically in relation to ovulation disorders, and we're going to get at how this links to digital tools in a moment, it can have an additional impact in women with pre-existing ovulation disorders such as PCOS, and those risks are concerning. And with a limited time window to intervene, keep in mind the question of how do you do that before they get into the clinic, and how do you keep that awareness going on for years after maybe they've completed treatment, et cetera. So this is just to take a look at the one variable of BMI. This is self-reported BMI within US and over time. So we have 2012, and you can see that the BMI, does increase. Slowly but surely, just with a time trend to a 35 to 40% overweight to obese category with time. And what we're seeing now is there may be increasing trends during the pandemic of BMI. And how do you manage this with BMI thresholds and very little to time to intervene? So while we do have guidelines, I think there may be issues with access to care for higher BMI. And digital tools may fill an unmet need here in being able to support counseling and caring for health optimization, not only in relation to BMI, but for some of the other exposures and social behaviors that I mentioned before for fertility. So we're going to turn to what are these digital tools for health and what can they do? Wendy, I'll turn this question over to you in a moment. But we all know that there have been increasing trends in smartphone usage as well as apps. 85% of women in the US own a smartphone, and the digital health sphere has grown astronomically with over 250 new health apps daily in 2020. 350,000 apps are downloaded greater than 5,000 times, and 110 apps have over 10 million downloads each, accounting for half of all the downloads. The COVID-19 pandemic has influenced an accelerated app adoption use for a variety of conditions, including chronic disease, mental health, overall health, ovulation, and menstruation, and including fertility. Okay, this is the question I'm turning over to you, Wendy.
Yeah, so we were wondering, do you have a sense of what health apps your patients are engaging with while they're undergoing fertility treatment or even before they enter your practice? If you have a sense of some apps that come up more frequently and you'd be willing to chat them, we can share those results. I would say a number of my patients seem to like the Clue app for menstrual cycle tracking. And let's see, we have a respondent. Most are saying that they're seeing their patients use them for tracking menstruation. Any other types of apps for different conditions that we're seeing amongst our fertility seeking populations? Okay, some weight loss. Oh, this is a Nourishly for improving relationships with food and health. So that sounds like a good one to be aware of and to share. The Billings app, nfpcharting.com, FEMN, and NeoChart. Interesting.
So I think that we're gonna, and participants and listeners should put into the chat any apps if they come to mind as we're talking. But I think there's been a huge transition as we move from paper to digital environments. So menstrual tracking was mentioned as one kind of major tracking tool, and this just shares how I used to hand out a menstrual chart in clinic for both, for mainly gyne care and irregular menstrual tracking, and have the patient fill this out and come back and share, look at the pattern in addition to kind of other diagnostic testing to understand what might be going on. And of course, now there are multiple different tools for menstrual tracking. Some are even embedded in your phone, like what is shown here in the health app called cycle tracking. You can track in many different interfaces. So it's very interesting how that has increased. My patients are coming in tracking with Clue or Flow or tracking into their digital calendar as a way of answering my question of when was your last period, or the nursing question of, when can we start the pills or get your day 3 testing. So menstrual tracking apps do account for the largest revenue share of women's health apps in 2020. One of the interesting things is that people are tracking for very different reasons. Some of it's personal menstrual health, some of it's family planning, some of it is fertility tracking or optimizing fertility and ovulation and timed intercourse. But some of it's just to inform their conversations with healthcare providers. And not every app does the same things as others. And sometimes it's they're tracking in more than one app to understand their own body. What these digital tools can do is facilitate kind of population level understanding of, specifically in this case, menstrual health. Different apps have different algorithms. And at least in my clinic, I have patients come in and say, this app has me ovulating on this day, but this one is a different day. How can you tell the difference, or what's going on? Oftentimes, because I don't have the algorithm and I don't know, we're back to the basics with kind of understanding physiology through blood work and ultrasound, but still it's something to be aware of as these tools grow. Wendy, in your clinic, are you seeing similar things?
Yeah, I mean, sometimes I have a moment of dread when they say, like, I want to show you my 3 apps because, ultimately I'm going to end up probably doing the same as you, where I say, like, let's prospectively monitor a cycle. I mean, I like the summary data. I would love if we could get to a point where this somehow communicates with Epic, or it can give you just like a concise summary so that you're not watching them flip through like screen after screen after screen, contemplating, is it like, am I most fertile on day 12 or 13? And also you don't want to see them be led astray by these apps, particularly if they're only having timed intercourse when their app instructs. I do worry about that sometimes, especially if the data that's being entered is inaccurate. So
yeah,
I think
or
for me, it's the time sink. It's sort of like wanting to educate them, but also not get too sucked into their apps. And then also like hoping that the apps are actually informing them.
Yeah, I do think there's a time burden in just parsing through the data from several apps in a clinic visit for sure. And then, because
they've obviously spent hours engaging with the app, and it's very important to them to understand the level of data, but it's not something we're currently using to like guide their fertility care. We sort of start with a fresh assessment. Let's see here. There is a question about calendar-based apps using the days of bleeding are of limited use. Other biomarkers, yes, like cervical mucus temperature or hormone monitoring are more effective. Yes, also having like a trained eye look at the data to help make sure they're not being led astray. Thank you for that comment. Yeah.
So there seems to be an uptick at a lot of different digital devices for at-home fertility testing and monitoring outside of the REI clinics. And these tools have also increased in popularity. A quick search in Amazon shows over 300 fertility tracking products and over 250 ovulation tracking products. A lot of these can be different companies that are startup with not as much published efficacy or validation data. So again, Wendy, I feel like looking at different streams of data, trying to understand and compare and contrast with the data we have from our clinic with the standard blood work and ultrasound. And here it's just that in-clinic evaluation is important to understand the patient's, ovarian function tests, as well as comprehensive couple-based fertility testing. But we are coming up against having to integrate potential data from a lot of different tools that might take in salivary hormone levels and urinary levels and basal body temperature measured by some sort of wrist monitor. So I think this is coming down the pipeline potentially. And the reason why I feel that way is some of my patients are coming in with this technology to kind of understand what more can I do in the clinic when they have all this at home. So in terms of getting it back to thinking about health optimization in the setting of digital tools, while menstrual tracking apps are leading the way in the health app space, kind of the next rung up are fitness, nutrition, and nutrition apps, mainly for weight and weight optimization and healthy lifestyle optimization. So these come in conjunction with some sort of wearable. So it might be a watch to track your heart rate for an exercise or fitness app specifically. And there are other apps that facilitate reflections on behaviors around eating, which have action planning, goal setting, behavioral feedback, and self-monitoring, all of which are really potentially outside the context of an REI clinic visit. However, it's important for us to know that these are out there and exist to potentially support patients that come through our practice. Wearables right now are being evaluated to understand how effective they are in supporting weight optimization and health optimization, and thinking about using these to maintain a healthy pre-gestational and gestational BMI is something that there is emerging research on. However, in the interval between kind of an initial visit and fertility treatment, some studies found that wearables did not really have a significant impact on weight loss. So that's just something to keep in mind as a time limitation.
I'll just share there's an app called Healthy, which actually does have an EMR online client portal. So that sounds very helpful, particularly for tracking reproductive nutrition counseling. Patients can check in with their goals, keep a food and mood journal, become more aware of their satiety, access approved handouts and resources, HIPAA compliant messaging with a dietitian. So that's a good one to know about. Thank you for sharing.
Yeah, that seems really great. I wonder what EMR, what kind of like interface that requires, but that does sound really great.
Yeah, this is the future.
So just bringing this back in and thinking about specifically here is weight, but we have all sorts of other social factors as well: tobacco, marijuana, alcohol use, as they wax and wane over the reproductive health timeline, and thinking about what is our intervention time window. It's very short, on the average of a couple of months to a couple of years, including treatment timelines. And so while many digital apps aim to enhance personal health management by helping users, self-diagnose, understand personal health, maybe reminders to take a medication or make a lifestyle or behavioral change. Some of these even have embedded consults with telehealth providers. Some reports suggest if there is ongoing interaction with these apps, it can help sustain healthy behaviors, improve access to health-related services. The clinical implications, I think, are huge. These tools may also help conversations about stigmatized topics easier, destigmatize things like social and behavioral health issues, menstrual issues, and weight-related concerns, whether it be behaviors around eating, and could potentially over long periods of time serve as a preventive intervention. I think clearly there's a lot of emerging tools, and I'm curious to know how they will mature over time to support our patient population over the life course. So I'll turn this over to you, Wendy.
Yeah, so we were just wondering if any of the participants have ever participated in a digital research study, as they become more ubiquitous, as you pointed out, that like more than 85% of women have a smartphone. Are others engaging in this type of research personally? Yes, no, or unsure. Looks like a few have. which is exciting. 4 of our respondents are participating or have participated. Most have not, and 1 is unsure. So.
Very interesting as we embark on potentially more digital studies. And here I'm just going to share a little bit about one digital study, online study that does integrate some of the digital tools I mentioned in thinking about, this work and health optimization. And so now I'll share a little bit about the Apple Women's Health Study. This is a study that enrolls completely digitally. One must have an iPhone to enroll, and the goals are to understand how demographic and lifestyle factors could impact menstrual cycles and gynecologic conditions, including infertility, menopause, and polycystic ovary syndrome across the lifespan. So participants who are interested and who hear of the study would enroll through the Apple Research app. It's on iTunes. Or it's on the App Store and downloadable. And the participants can review any available studies, learn about and decide whether or not they want to embark on an informed consent process for any of the potential studies, one of which is the Apple Women's Health Study. They choose which data to share and review. They also can manage the data that's been collected. And then they're given surveys to fill out and perform. These are called tasks. And they also have the potential, depending on the study, to learn more about how their data has contributed to some sort of discovery. So this specific study includes digital data collection through surveys, similar to prior surveys like the Nurses' Health Study or the Framingham Heart Study. But these survey questions have been revised and curated for an online kind of mode of access and response. They can also share their menstrual tracking data as well as logged symptoms around a menstrual cycle, whether or not they're attempting conception through any cycle tracking app that they have or the cycle tracking feature within the health kit. Those who do have sensor data can share that, and that includes heart rate, and we'll talk a little bit more about that in a moment. But just to kind of share where we are with this kind of information. So we launched just before the pandemic in November of 2009, and this is just a little bit of a data summary through October 2021, which is around 2 years. And we've had engagement with large, kind of like big data kind of numbers, 450,000 surveys, 720,000 menstrual cycles logged, and 2.4 million reports of menstrual symptoms. And, we're learning what this all means. And as we do that, we've provided some kind of informed study updates, and those in the audience can use the QR code to come and look at these study updates, but they have been on the topics of pregnancy attempts during the COVID-19 pandemic, menstrual symptom data and what the implications are around stigma and cycle symptoms, and then just some information around the benefits of tracking your period. And so this gives the study team an opportunity to provide informed kind of messaging around these topics available for both participants in the study and the general public. So what does that look like in terms of taking big data from digital health tools and using it for research? So we were able to kind of look at a much wider distribution of menstrual symptoms among those who track. And just shown here are the distribution of those who track across the symptoms, and we've looked at this data in a variety of ways to understand who might be tracking these symptoms more readily and what are the similarities within the population around tracking. We've taken a look at among those who responded that they were attempting conception in a menstrual cycle, how that varied across the pandemic to gain insights at population level health that might also then inform us in the clinic. Interestingly, what we're seeing at a population level here is not what we see in the clinic. And Wendy, you and I have talked a little bit about this. I think we've seen so many people come in during this time for fertility care, whether it's preservation for the future or initiating a fertility cycle. I don't know if you have any thoughts on that right now to share.
Yeah, I think it's just interesting that in your population data, and I'd be curious if you could just comment on like the makeup of your cohort and how it compares to the population in general with respect to like age, section of the country, because obviously we've experienced the pandemic a little differently depending on where the surge is and what part of the country you're in. You want to comment on that?
Yes, definitely. So one of the unique things that we found with the study, and we looked at the first 10,000 participants, we did see, compared to other large population-based cohorts, more inclusivity in terms of both geographic variation across the entire United States and territories, as well as race ethnic diversity, with a distribution, at least at enrollment, that more mirrors that of the US population.
Yeah, so we as fertility providers see a very select and privileged group of patients that ultimately get to access our care. So while we feel like demand for fertility services is high, I mean, looking at your data, it looks like it sort of the percentage of individuals attempting pregnancy initially bumped, but then it's really been a plateau since looks like September of 2020.
Yeah, it is
big
interesting.
Implications for the country.
Yes, in terms of birth rates and different things. So, we do have to be careful when we think about digital tools and how we take that data into research. Who is the population contributing that data, and who is that data, that insight generalizable, to whom is that generalizable? And I think that is a really important thing as we kind of navigate between these accessible tools and then the fertility clinic population specifically. I'll just conclude a little bit here. This is the paper that describes our demographics from the initial 10,000, and which has stayed relatively stable throughout time. And one of the things I wanted to mention is that the Apple Watch is not required for participation, but this has a sensor that allows transfer if a participant elects to share their heart rate and their blood O2 sat. Just to think about the unique kind of data streams that could potentially inform our work in thinking about optimizing health across the lifespan. We talked a little bit about how this might, facilitate insight not only at the population level, but at the individual level as well, to understand subpopulations. But and with that, I will conclude. Wendy, I know you had a few points you wanted to bring up now. So in summary, I think that we have a lot to learn about how these digital tools are going to inform clinical practice. I think there are a lot of emerging apps. We've heard one in the chat that directly interfaces with the EMR. I'm excited to learn more about that. And as we take kind of some of the knowledge from a population base, both specifically into the clinic, but also other large populations to think about access to care. I'm excited to learn more about that. And I wanted to thank all of my research team. Some of the slides I showed here today wouldn't have been possible without them. And it definitely takes an army to run a study like this. So thank you, Wendy, and I'll turn it over to you.
Yeah, well, I will clap on behalf of our audience. Thank you for walking us through this like new and exciting space. I'll just allow anyone in the audience, please feel free to chat a question and I'll help to share that. I'm just, thinking like 5 years from now, what do you think will be the most, what are you most excited about in this data set? Like what data are you dying to get information on? Given the
so many things,
troves and troves of data you'll be able to collect from this really impactful.
Yeah, thank you for that question. I think there is a lot that we're just still trying to unpack, and we're doing a lot of data exploration. What can we use and what can we use to answer kind of the most important questions? I think some of the important questions include, questions around how can this help patients, stay healthy across, like what behaviors are associated with long-term health that converges on fertility. But then, what's the before and after look like there? I think that's something that's interesting and important to me. And I think a lot of people will, have thoughts on how this kind of data can inform population level care, but also kind of all the way take it into personalized care too.
Definitely. Yeah, I mean, I love the where this conversation's going in the chat, because I really am happy to see that many in our audience are really pushing us to think beyond BMI. I think, certainly we need to for our patients. It's one piece of information. And this relentless focus on weight optimization has just led to weight cycling and more potentially like eating disordered behaviors. Pairing that with fertility treatment, it's no wonder that anxiety and depression are so comorbid in our population. But Rochelle comments along those lines that she would love to see, they would love to see data on health promoting behaviors and how those improve fertility and other health metrics in the absence of weight loss. So I think I took a peek at your Gray Journal paper, and it looks like you're going to have quite a bit of data on various health behaviors. You mentioned a couple related to like substance abuse or exposure. I know your personal interest is on toxins. Do you want to comment on what types of data you're hoping to collect?
Yeah, there's a question in the Q&A also, I think, around what you just mentioned too, from Judy Simon. Recent papers have found there's a higher rate of eating disorders past and present in the fertility population. How can we be sure these digital platforms screen for mental health? And I think this is a really important point. I think as these apps are being designed for use in the clinic, I think we have to be very careful in designing them for clinical use and for usability, acceptability, so that they actually destigmatize what we're trying to do and promote health and not contribute to that. And I think about this the same way I think about access to care. Are these tools and apps increasing access to care, or are they magnifying the divide in accessing care?
Yeah, what did you find when you looked at the demographic data in your first 10,000 users in terms of like income or other markers of SES?
Yeah, I was surprised in how kind of global the population is. There was an educational distribution across the distribution of from below high school to beyond high school. And there was also a distribution of SES. We asked a question that's based on the MacArthur socioeconomic scale. So there's not a hard monetary self-report of income. So that is something to keep in mind, but it's self-perceived. So social economic status, which has different types of correlations to different health parameters. So yeah, it's not an absolute value of dollars, but it kind of, you can self-report on a ladder scale compared to people who you perceive in your own, social and economic sphere. So it's another marker. It's very different than an absolute dollar value though.
Interesting. Yeah. Sorry if you can hear my son, he's playing a video game, but any other questions from our audience? Yeah, I mean, the other thing I noticed in looking at your demographic data is that it's definitely mirroring what we're seeing in our clinic. You had quite a I thought impressive number of trans patients, gender diverse, or those that chose not to answer. And that's a population that may feel stigmatized, and particularly around menstrual stigma, which isn't something I really have thought about coming from my place of privilege. Is that something you want to comment on, is like using this data to help those with menstrual stigma?
I think this study does have the ability to take a deeper look at that. And in the conversation around stigma, just starting to be able to track and report on symptoms and kind of open up the conversation is one first step. I think every, gender non-binary group has different needs, and we will, learn more about those groups. The name of the study is Apple Women's Health Study, but we're very clear in our inclusion criteria that it's inclusive to anyone who's ever menstruated once. So that's definitely true in our clinical population as well, in terms of gender inclusivity as we move forward.
Yeah, I noticed you said like people who menstruate multiple times. So I'm glad that you're including this information, because we really don't have population level data on this emerging group that we're seeing more and more in our offices, and unfortunately learning with them. They're teaching us as much as we're trying to learn how to help them. But another participant says, awesome to hear that you're considering gender inclusivity. So great job in leading the way on that. Yeah. Do you think, it's again hard to know, like 10 years ago we were on paper and now phones and watches. Do you think Apple has a vision, or you as one of the lead investigator has a vision that this could be decades of longitudinal data, or do we think we're all going to be using like glasses in the future and that this is just one blip in the iteration of digital data? Like, it would be amazing if you had cohort data that really could get to some of the factors that lead to earlier menopause or diminished ovarian reserve, because certainly lifestyle likely is a factor, but we haven't really been able to fully recognize that as a potentially modifiable factor.
I agree. I think some of the power in a study like this is its ability to track over time. And I do think that, getting a sense of those factors in early menopause, an area that we're still thinking a lot about, is one of the potential, strengths of a study like this. You had asked before about environmental exposures. That is my area of interest. And, being able to get a sense of how different exposures that may be varying geographically, how those might affect the cycle and potentially, attempts at conception, is something that is really, really interesting to me. And I'm excited about the potential of this cohort to be able to give us insight on that too.
And I missed this before. Did you enroll adolescents? Like, will we be able to look forward to data on like PCOS, like over the
adolescents,
20s and 30s?
But maybe we could, if there's enough interest here, we can think about a new study somehow. But I do think understanding the adolescent transition is very important.
Well, great. Just give the audience another chance to comment. Any questions? Yeah, a lot of interest in the audience about toxins. It's just, patients always ask, like, is it something I'm doing, something I'm exposed to? Why is my reserve low? Why do I have PCOS? And it's probably, but we can't really answer with the data at this point, at least not solid data. So I'm getting like going to be really helpful. Lots of thanks to you from our audience. They're all very excited about the Apple Women's Health Study. So
Well, thank you so much for the opportunity to engage in this conversation with you, Wendy, and with our viewers today and with the ASRM. So this is exciting work.
Great. Well, keep the data coming. We appreciate it.
Okay, thank you.
All right. Take care.
Bye. Bye, everyone.
Bye.
Thank you, Drs. Vitek and Mahalingaiah, for such an engaging session and a timely topic for discussion. To the attendees, thank you for joining us. You will receive a survey right after the session and by email after this session. Your feedback helps us give you the most relevant content, and your input is appreciated. This session was recorded and will be available on our website in the near future. Please watch your emails for notification about future webinars. And for any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar. Good night.
Okay. Good night. Thank you.